So now that we covered leukemia and we talked about blood transfusions, we are going to move on to your lymphomas. Now remember, a lymphoma is a malignant neoplasm that originates in the bone marrow and also lymphatic structures, and it results in a proliferation of lymphocytes. Lymphoma is the 5th most common type of cancer in the United States. Now in your book, they start to talk about this in chapter 40 on page 817. When we're talking about lymphomas, there's two major categories. You have Hodgkin's and you have non-Hodgkin's. Now remember, Hodgkin's lymphoma can affect any age group. However, we have seen that it peaks in 2 age groups, and typically that's your teen to young adults, and then again your adults ages 50 to 60. Hodgkin's lymphoma is a very curable form of cancer. In your early stages, the 5-year survival rate is greater than 90%. Even if we don't catch it till it's more advanced, if we treat it very aggressively, then that person has a greater than 80% survival rate. So those are really good odds. And Hodgkin's lymphoma, remember, it starts in a single lymph node or a chain of lymph node. And the tissue within that lymph node, it becomes cancerous. Now, when we talk about risk factors, remember, we don't know the exact cause, but we do know that there are some risk factors that increases the risk of developing this. We do know there is a higher incidence among males. We do know you are at a higher risk if you have a family history. Also exposure to chemical agents. If you have any type of immunodeficiency. And then also we're looking at possible causes including interaction with viral infections such as Epstein-Barr and also HIV. Now, one of the key features of Hodgkin's lymphoma is that this lymph node contains a very specific cancer cell type, and it is called a Reed-Steinberg cell. So that is one key feature. The other key feature is that Hodgkin's lymphoma generally spreads from one group of lymph nodes to the next in an orderly fashion, okay, until eventually it's going to infiltrate the lungs, the spleen, the liver. Symptoms of Hodgkin's lymphoma, remember that most people are asymptomatic when they're diagnosed. Usually what happens, they come in because they have an enlarged lymph node that's painless. It just will not go away. This lymph node is usually in the neck, but it could also be under the arm or even in the groin. We have something we call secondary symptoms. If someone has secondary symptoms, they're also called B symptoms. This means that person has a poor prognosis. Some of these secondary symptoms are an unexplained recurrent fever greater than 101.5, generalized itching, just a vague overall feeling of not feeling well. They can't really pinpoint it, they just don't feel good. They have night sweats, and they also have unexplained weight loss. Again, remember, these are B symptoms, and it means the person has a poor prognosis. Now, when we talk about staging and diagnosing, remember, we diagnose it because with this type of cancer, it has the Reed-Steinberg cells. Now, the reason we stage, it helps the healthcare provider determine the extent of the cancer. So some things we look at the H&P, we do a physical exam. We will also do some lab work, and typically if you do a blood analysis, you'll see that these people are anemic. They have high calcium levels, and they have low albumin levels. Other tests that we'll do, we can do a CT or MRI, and again, this just helps us with staging, and it tells us how advanced the cancer has become. Now, PET scans, that's something we do a little later on, and that's to assess the response to therapy. Okay. I like to put this example up here because this is a staging system for Hodgkin's and non-Hodgkin's lymphoma. So when we're talking about a stage 1, remember that involves just a single lymph node. Now what will happen is you will have these numbers, and then they're going to be followed up by an A or a B. A means they're asymptomatic, meaning they're not having any other signs or symptoms. Now if they have that B, remember they have those symptoms that I talked about previous, the unexplained recurrent fevers, the night sweats, the generalized itching, the unexplained weight loss. These are called B symptoms, and remember this means they have a poor prognosis. So I just like to put this up here for you to kind of get a visual of this is how we stage. Now remember your stage 2, it involves 2 or more lymph nodes. Okay, and then your stage 3, of course, involves lymph nodes above and below the diaphragm. And then your stage 4 means it has just metastasized to other places. This is another great example. This is Hodgkin's lymphoma, stage 2A. So what that tells us is that he has 2 or more lymph nodes in the same area that are involved. And remember that A means he's asymptomatic. This was his only issue. Okay? So remember that this form of Hodgkin's lymphoma, it can be very localized or it could be very diffuse. It just kind of depends. Okay. So let's look at our treatment for Hodgkin's disease. Well, the treatment kind of depends. It depends on the actual stage of the disease, how large are the lymph nodes, are there any symptoms? Remember, we're looking for those B symptoms. And then also, what's the general overall health of the person? All of these things determine what type of treatment options we're going to do. However, remember, we're going to treat them very aggressively. So you want to educate them about infertility and the need to take measures for this possible outcome. Our treatment of choice for advanced or a refractory Hodgkin's lymphoma is a bone marrow transplant. But again, remember, not everybody is a candidate. So a lot of times what they're going to do is we're going to do some combo chemo, just like we talked about with our leukemias. And so you have to be aware of all the nursing interventions that are involved there. And this picture that you see of this lady, that is what she is getting. She is getting some combo chemo. Now, remember I told you I like to give, or I should say most people like to give chemo through a central line, but you can give it through an IV, but you better watch your IV site because chemo is a vesicant, so it'll eat the vessel and all the surrounding tissue, so you have to monitor this closely. Another option that we can do is we can do radiation, which is this other picture up here. Typically we do radiation for local therapy because it treats it in it treats the cells in a localized area. Okay, so radiation kind of depends on where is the cancer at, how widespread is the cancer. Okay. So these are just some of our treatment options for Hodgkin's. So when we talk about nursing management for people that are undergoing Hodgkin's lymphoma, what you have to realize is we're treating it the same as we are for our leukemias. So most of these people, they're going to get combination chemotherapy. So all those things I talked about earlier, they still apply. We still have to know how to take care of them. We know that they're going to have drug-induced pancytopenia, which makes them at an increased risk for infection. So be on the lookout for that. Talk to them about ways of preventing infection. We know that nausea and vomiting, either from the disease process or from the chemo, is going to be an issue. So that's going to impair their nutritional status, and it's also going to inhibit them from gaining weight and generalize just being healthy. So do the interventions we talked about for leukemia for this. We're going to have skin problems and we're going to have mouth problems. Now, skin problems, it's more at the site of radiation if they get radiation. But again, remember that a lot of people get stomatitis and they get thrush. This is a great picture of stomatitis right here. So if you have a patient that has this type of issue, this is the one you do the normal saline rinses, especially after meals. Tell them to avoid acidic, spicy foods. Now, constipation and diarrhea or issues. We usually can't find a happy medium. You're going to have one or the other. So you need to be aware of that and be aware of the interventions you can do to prevent those things from occurring, or to combat, I should say. Okay. We also can have impaired liver function, again, from the disease or from the chemo that we're getting, so keep an eye on your liver functions. Sterility, like I said, we are giving really high doses of chemo. So for most people, they will become sterile. So this is why we taught them about egg harvesting and sperm banking before chemo ever starts. And another thing that can cause that they could develop is they could develop a secondary cancer. This happens in about 2 to 6% of patients, and it's just a result of this chemo that we've given them. If they're going to have a secondary cancer development, typically it's going to occur within the first 10 years after treatment. And some of those secondary cancer developments that you'll see, it could be non-Hodgkin's lymphoma, it could be solid tumors, or they could develop AML. So that is everything we need to do for Hodgkin's lymphoma. So now we're going to move on to non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma is the most commonly occurring hemolytic cancer. It includes all of your lymph node cancers that do not have that Reed-Steinberg cell. Okay, so currently we have more than 12 subtypes, and I just have kind of listed some for you. What's interesting about non-Hodgkin's lymphoma is that the more aggressive the tumor, the more responsive it is to chemo, and the greater chance for a long-term cure. Okay. When we talk about risk factors, your risk factors, they're essentially the same as they are for your Hodgkin's. A family history, okay? Exposure to chemicals, infection with virus, and like I talked about earlier, HIV, Epstein-Barr, hepatitis C. Also a history of chronic infection with H. pylori. And also autoimmune conditions such as celiac, lupus, they put you at a higher risk for developing this. One other risk factor is organ transplants. You want to think solid organs, and the reason this puts someone at risk is because, remember, if you get a transplant, then you have to be on immunosuppressive therapy. So that puts you at a greater risk for developing this form of cancer. Now, when we talk about symptoms, remember your symptoms could be a painless swelling of a lymph node. Okay? And that could be your only manifestation. So you need to remember that non-Hodgkin's lymphoma originates outside the lymph node. Therefore, the method of spreading is very unpredictable. Okay? So by the time most people are diagnosed, they have widespread disease. Now, when we talk about staging, remember what we're going to do is we are going to do a bone marrow aspiration and or biopsy. And then our staging is very similar to just like Hodgkin's lymphoma. Okay. So then when we talk about treatment options, one option that we have for non-Hodgkin's lymphoma is we call it watch and wait. Okay, this is an option for our people that have a low grade non-Hodgkin's lymphoma, and the reason this is remember the lower grades, they don't respond as well to treatment. So what we do is we just monitor the patient's condition very closely, and we don't do anything until signs and symptoms start appearing that actually affect that person's quality of life. Now, another option we can have, if we have found that it is in a very localized area, that it has not spread throughout the body, we can use radiation. Okay. And remember, this radiation is going to kill the cells in that area that are growing and dividing. Okay. However, one therapy that we have really started using in non-Hodgkin's lymphoma is called targeted therapy. Now, I talked a little bit about targeted therapy to you in our last lecture, but remember, we like targeted therapy because it attacks specific types of cells, and our body reacts better to targeted therapy because it's not killing everything. It is very specific. A great example I provided for y'all is Rituxan. And this, what they do is it targets a specific marker, and it also enhances your own immune system so it can find and destroy those cells. Okay. And then if we have found that the disease is throughout your body, then what we do systematic chemotherapy. And again, when you're giving somebody chemo, you have to worry about all the side effects that go along with chemo. Another option I always like to talk about, and I know it says spleen, we're removing a spleen, and you're like, well, why is this in here? Well, remember that a lot of your leukemias and a lot of your Hodgkin's and non-Hodgkin's, they're cancers that affect the spleen. So if cancer is found in the spleen, or we have spleen enlargement as a result of these cancers, then we can remove the spleen. Okay? Here's the thing you have to realize, though. the spleen actually has functions. One of its functions is immune protection. So people that have had their spleen removed, they're more at risk for infections. And so with that population, you really want to drive home the point of they need to get their yearly flu vaccines. They also need to get their pneumonia vaccines, okay? Because they don't have their spleen, which performs some of this immune protection, so they're more at risk. Now, before I move on to multiple myeloma, really what I want you to know about non-Hodgkin's lymphoma, or one of the most important things, like I said, the more aggressive the cancer, the more responsive it is to treatment, and the more likely it is to be cured. When we talk about non-Hodgkin's lymphoma, remember that most people, they relapse several times, and a cure is very unlikely. Okay, so this is something they'll be dealing with for the rest of their lives. Now, when we talk about multiple myeloma, remember that multiple myeloma, it's a cancer of the plasma cells. And what's happening here is you're having an overgrowth of your B lymphocyte plasma cells. And y'all remember your B cells, they make antibodies. And so when these excess amount of antibodies are released into the bloodstream, they're going to increase the serum protein levels, and they're going to clog blood vessels, especially in the kidneys. Okay? So if I had to sum up multiple myeloma, there's really two things you need to realize. One, you're having excess antibodies being produced by the B cells. Okay? Those excess antibodies, what happens is they crowd out all your normal blood cells, and they make the blood very thick. So if your blood's very thick and it's trying to go through really small vessels, what's going to happen is it's going to become clogged. It's not going to be able to get through. So that's the first things that happening. The second thing that's happening is those myeloma cells, they produce excess cytokines, and those cytokines, they're needed for cancer cell growth. Okay? So when I have all these excess being produced, my cancer cells are going to increase, and also this is going to destroy bone. So without treatment, multiple myeloma, it leads to progressive bone destruction, bleeding problems, kidney failure, immunosuppression, and eventually it's going to lead to death. So when we talk about symptoms of multiple myeloma, remember that up to 20% have no signs or symptoms when they're diagnosed. If they do have symptoms, the biggest complaint I should say is bone pain, especially around the spine and ribs, and it's worse with activity. They also are more prone to infection. One of the biggest things they're at risk for is pneumonia. They can have some neurological changes. They can have visual changes, confusion, weakness. They can have headache. These people have signs and symptoms of renal failure. Okay, so remember that right there is they could be anemic. They could have high calcium levels. So a good way to remember multiple myeloma is just think crab. Okay, because in people that have multiple myeloma, they have elevated calcium, they have renal failure, they're anemic, and they have bone lesions. Now when I talk about these bone lesions, here's a great picture of it. You see how these x-rays, the bones look like they have all these little darker spots, and it looks like Swiss cheese. That's actually destruction of the bone. So when I tell you their biggest complaint is bone pain, especially with activity, can you see now why that would hurt so bad? It's because their bone is actually being destroyed. So that being said, you need to make sure that you handle these patients very carefully because they are at increased risk for fracture. Now, we make the diagnosis of a multiple myeloma through a bone marrow biopsy. Okay? And another key feature of multiple myeloma is a protein that is found in the urine, and it's called Benese-Jones. This is actually just a chain of protein. It's made up of plasma cells that are small enough that it actually passes through the urine. So that is the key feature of multiple myeloma. So when we talk about treatment for multiple myeloma, what you have to realize is the only curative treatment we have for these people is a bone marrow transplant. Okay, and again, like I've told you earlier, not everybody is a candidate for a bone marrow transplant. So we generally considered multiple myeloma to not be curable. Okay, so again, we focus on disease containment and suppression. What I provided for you, this is just a standard treatment for chemo. Like I said, we do a combo chemo again, so it's a very harsh chemo for them. Now the last thing I want to talk to you about is hemochromatosis. This is the most common genetic disorder among Caucasian males, and really it's a disorder of iron regulation. It's an iron overload disorder. It can be caused by a genetic defect, but it also can be caused by liver disease or multiple blood transfusions. What's happening in hemochromatosis is all of the iron, the body is not able to metabolize it, and so it goes to the organs. Your two most commonly affected organs by this are your liver and your pancreas. Okay. So what we have to do for someone who has hemochromatosis is we have to remove the excess iron from the body. And we also need to minimize any symptoms. So we do this by removing about 500 mLs of blood each week for about 2 to 3 years until we have actually depleted the iron stores in the body. And I know you think, oh my gosh, that is really excessive. But here's what you have to realize. Okay? Most symptoms don't develop until that person's between the ages of 40 and 60. So they're not able to metabolize and get rid of this iron. So these iron levels in their body are going to be off the charts. They're going to have lots of extra iron throughout. So while I know it does seem excessive, it's, if you think about it, if I've had this disease and I've not been able to get rid of my iron for 40 years, then you know that person's iron store is going to be really, really high. So that's why it takes 2 to 3 years to remove all of the iron from their body. Okay. So once we've depleted their iron stores, then what we're going to do, we will still have them come in and we will still remove blood from them, but it's not going to be as often, because what we want to do is we want them to be able to maintain iron levels within normal limits. We also talk to them about dietary modifications. Some things we talk to them about is we want them to avoid vitamin C and also iron supplements. They need to avoid iron-rich foods, and they also need to avoid uncooked seafood. So when I talk about hemochromatosis, remember it does occur more frequently in men. And it, again, like I said, it's not usually detected until there's permanent damage. So some of the early symptoms are very non-specific. Okay, you have fatigue, abdominal pain, weight loss. But then some of your later signs, you're going to have liver enlargements. So then you would look for your signs and symptoms of cirrhosis. You're going to have arthritis because the iron goes somewhere, and once it's saturated the organs, then it goes to the joints. You're also going to have some skin pigment changes. So these are things that you would be looking for in someone who had hemochromatosis. Now, the labs that we usually do for these, we will do serum iron and their total iron levels, and what you will see is they will be through the roof. Now, we also will do a liver biopsy, and this liver biopsy, it actually lets us know the amount of iron that has been stored in that person's body.